Welcome to NICU Essentials lecture series. Today we'll be talking about apnea of prematurity. Today we'll be doing an overview of apnea of prematurity. We'll be going over the official definitions, the epidemiology, monitoring, treatment options, as well as discharge planning and coordination. An apneic spell is defined as cessation of breathing for 20 seconds or longer, or a shorter pause accompanied by either bradycardia, less than 80, cyanosis with the oxygen saturation between 80 and 85%, or pallor. Etiology of apnea of prematurity can be classified as either central, aka cessation of breathing effort, obstructive, airflow obstruction, or mixed. Nearly 100% of infants born less than 28 weeks will have apnea of prematurity. It was found in one study that 85% of infants born at 30 weeks had clinically defined apnea of prematurity. 20% of those born at 34 weeks were also found to have a clinically defined apnea of prematurity. Apneic spells stopped by 37 weeks corrected gestational age in 92% of infants, and by 40 weeks corrected gestational age in greater than 98% of infants. Of note, infants with bronchopulmonary dysplasia have delayed maturation of respiratory control, which can prolong apnea. So why do we care about apneas? Ventilatory and perfusion disturbances from apneic breathing patterns are associated with various sequelae such as retinopathy of prematurity, altered growth, discordant cardiovascular regulation, as well as neurodevelopmental disabilities. In the neonatal ICU, monitoring for apneas and bradycardias is done via continuous pulse oximetry and cardiac monitoring. Apnea alarms are often set to 20 seconds. It is important to note that the diagnosis of apnea of prematurity is not associated with an increased risk of SIDS. However, infants born preterm have a generally higher risk of sudden infant death syndrome. It is for this reason that routine home monitoring is not recommended for home, given that most apnea and bradycardia events resolve by 40 weeks corrected gestational age. There are many preventative measures that are done in the neonatal ICU unit. One such measure involves positioning of the infant. Avoiding extreme flexion or extension of the neck can help maintain the patency of the upper airway. This is often why you may see some infants in the neonatal ICU in prone positioning. It is also important to provide a stable thermal environment, ensuring that the infant does not become hyperthermic nor hypothermic, as this can also precipitate apneic spells. It is also important to limit nasal suctioning and use heated, humidified air to maintain nasal patency. Maintaining an oxygen saturation between 88 to 94% is also key, as hypoxia can stimulate apneic episodes. We will now move on to various treatments that are used in the NICU for apnea of prematurity. One of the most important medications that is used in the treatment of apnea of prematurity is caffeine. Caffeine works by blocking the adenosine receptors. It helps treat apnea of prematurity by increasing minute ventilation, improving CO2 sensitivity, decreased periodic breathing, decreased hypoxic depression, improved diaphragmatic contractility, as well as shorter duration of mechanical ventilation the earlier the treatment is initiated. Caffeine is recommended for all infants born less than 28 weeks, as well as infants born between 29 and 32 weeks, depending on clinical course. Treatment with caffeine is often initiated by a loading dose of 20 milligrams per kilogram, followed by maintenance dose of 10 milligrams per kilogram per day. A trial off of caffeine after an apnea-free period of 5 to 7 days or at 32 to 34 weeks corrected gestational age is often recommended. Side effects of caffeine include tachycardia, cardiac dysrhythmias, seizures, feeding intolerance, as well as increased metabolic demand. Another treatment used in apnea of prematurity is nasal continuous positive airway pressure, or nasal CPAP. Pressures of 4 to 6 centimeters H2O in conjunction with caffeine therapy has been shown to reduce the severity of apnea. Nasal CPAP works by splinting open the upper airway to prevent pharyngeal collapse, decreasing the risk of OSA. Nasal CPAP also aids in decreasing the duration of O2 desaturations during central apneas by helping maintain higher end expiratory lung volumes. A second-line treatment for apnea of prematurity are blood transfusions. It is thought that blood transfusions can increase the respiratory drive resulting from increased O2 carrying capacity and increased tissue oxygenation. It is controversial whether treatment of gastroesophageal reflux disease reduces risk of apnea. It is thought that the hyperreactive laryngeal chemoreflex may precipitate apneas. However, timing of reflux episodes in relation to apneic events are rarely temporally related. From a hospital discharge perspective, infants should be free of significant apneic or bradycardic events for a period of 5 to 7 days prior to discharge. It is recommended to initiate countdown period a few days after the discontinuation of caffeine therapy. It is important to note that brief, isolated bradycardic episodes that spontaneously resolve and are feeding related should not be counted in the countdown period. This concludes our lecture on apnea of prematurity.